The front page of the Sunday Business Post was a horror story, I think, for chemists and pharmacists around the country. It was a proposal from the National Association of General Practitioners, and they were looking at the possibility that you go to your GP, you wouldn't just get a prescription, you get the drugs, and directly dispensing the medicine to the patient by the doctor. This, of course, would cut out the pharmacist. Over €2.7 billion spent each year on medication through pharmacies. Well, to debate this and see whether it's a practical non-runner, and to hear, I'm sure, the howls of protest from the Irish Pharmaceutical Union, we have in studio Darragh O'Loughlin, General Secretary of the aforesaid IPU, and on the line Dr. Emmett Kerrin, President of the National Association of General Practitioners, who are behind the proposal. If I could start with you, Emmett, is this flying a kite, or is there a plan in this regard?
Good morning, Ivan. Thanks for having me on the show. No, I wouldn't say it certainly it isn't kite flying by any means. I mean, what we're looking at is a number of areas of where we could actually make savings to the state in terms of, as you've rightly pointed out, 2.7 billion is spent on drugs in the country, and we're looking at making significant savings to the state, and for that saving to go back into primary care to actually support the transformation that we're promoting in healthcare reform. That we need to get funding into primary care, and this is one of the means of doing that.
Just explain how it would work. I mean, like, I'm thinking of a busy doctor's surgery that I go to in Sandymount, crowds of people in the waiting room, people behind time, whatever. Just imagine, you go to the secretary afterwards to pay your bill and get your prescription. Are doctor surgeries capable of carrying all the stocks and doing the logistics of distribution for this kind of thing?
Yeah, well, that's what we're looking at in the feasibility studies, kind of supply, stocking, storage, the logistics of dispensing and that. What we're proposing is looking at medical cards and dispensing to medical cards. There'll be actually no change of money happening, and there'll be a service for medical card patients. When we look at the figures, 40% of scripts generated in practice are just for one item, and 19% are for two items. And the top ones in that are aspirin, paracetamol, Calpol, PPIs, drugs like that. So, I mean, it isn't exactly rocket science, and it isn't the complex prescriptions with multiple meds on that. I mean, you certainly need the role of the pharmacist from that point of view to have a look at those. So I think, keeping it simple at the start, if it can deliver a saving to the state, I think we all have a responsibility to try and achieve that.
Okay, well, let's get a reaction. Darragh O'Loughlin, Emmett really confining it there, saying medical card holders only, and maybe some of the most voluminous drugs. Seems to make sense. It will be a one-stop shop for the medical card patient.
Yeah, for generations, best practice in healthcare has been to separate the prescribing and the dispensing functions. So across the entire Western world, doctors make a diagnosis, doctors write a prescription, and the prescription is dispensed by a pharmacist. And there have been various cases that have arisen around the world that have reinforced the need for that separation. So when a doctor writes a prescription, he's using his skills and his expertise to make the diagnosis and choose the right therapy for the patient. But that prescription then is reviewed by a pharmacist. It is an essential patient safety step. We all know that somewhere between 1 in 12 and 1 in 15 prescriptions is going to have an error on it. That's a medical council statistic. The pharmacist's job is to pick up on those errors and to make sure that the patient gets the right medicine that was intended for them, that's suitable for them, and that's not going to interact with any other medicines that they might be getting today or have gotten previously, and that they know how to take it.
But, I mean, Emmett is making the point that this could be a saving for the taxpayer. I mean, really, surely you're just a vested interest looking to hold on to a fat margin.
The price that the state pays for medicines on the medical card scheme is set by the state. The legislation is there, so the HSE, as the competent authority, decides what the price is. There's a mechanism for agreeing pricing with the industry. But whether a doctor hands the medicine out or a pharmacist dispenses it, it's the same price to the state. The price is based on the ex-factory price agreed between the industry and the HSE.
But is there not a markup for the pharmacists do it for nothing, do they?
Pharmacists don't have any markup item. They get a professional fee, just like doctors get a professional fee.
But you cut out that professional fee.
I don't think that it's really, I don't believe that a profession like medicine that says that it's hopelessly overworked, that they can't cope with the workload they have today, that they're under-resourced and undermanned.
That's a separate point. You
and
would
which
cut
we
out the
agree
fee. How
needs
much
more
is the
resources.
prescription fee?
The prescription fee per item is €3.50, whether it's a €300 medicine or a €3 medicine. That fee is set by the government. But we've been listening to GPs all of this year and all of last year saying there aren't enough of us, we have too much work, we're under too much pressure. So it's hard to understand why they think they can take on this additional workload when there isn't enough of them at the moment to cope with the workload that they have. It would make more sense if we were talking to each other about how we improve the lot of patients and how we improve the healthcare of patients in primary care, rather than having people going into hospital for procedures and for outpatient department appointments that could as easily have been dealt with in primary care.
Emmett, is there any other international blueprint model that you would point to that actually does this, where the doctors dispense as well as prescribe the medicines?
Yeah, I'd say Ireland would be the answer to that, Ivan. We have 108 dispensing rural doctors in the country who do exactly this, where there isn't a pharmacist. And the other point, certainly here in Limerick, the out-of-hours service, like Shannondock, we actually dispense medications because the pharmacists are closed after 10 o'clock at night. So we're actually doing it here in effect anyway.
What about that, Darragh?
What Emmett is talking
this is
about
already happening.
What Emmett is talking about is the exception. If we went back to the 1950s, most of the doctors are dispensing doctors, but as the profession of pharmacy has grown and as more people have access to pharmacy services, fewer and fewer doctors need to be dispensing medicine. There is no argument that it is safer for medicine to be dispensed by a pharmacist having been prescribed by a doctor. The review of the inquiry into the Harold Shipman case is the most extreme in the UK, but the report of that inquiry said that it's crucial that the prescribing and the dispensing of medicines be separated for patient safety reasons.
We have a couple of texts for you, Emmett. What about a conflict of interest with a GP providing expensive drugs might be in their own interests, asked Martin?
I go back to my first point that this would be the medical card service. There actually wouldn't be any money changing hands between the doctor and the patient, and that money would go into a transformational fund for the reform of primary healthcare. So I'd say that there isn't a vested interest from that point of view.
And there's another tweet here, and this is a bee I have in my own bonnet. I get repeat medicines, identical for Ventolin and Becatide inhalers and anti-inflammatory and painkillers for my back. It's the exact same thing. And the doctor says, oh, no, we can only give you a prescription maybe for 3 months, which means I have to go back for a renewal of a prescription, time in and time out for the same drugs. You know what? I have to pay for that service. What about if you're interested in cutting costs, cutting out fees for prescription renewals?
Well, in that time frame, Ivan, typically for that prescription, it would usually be about 6 months, and that affords the time for the doctor to have a look at your chart, make sure that was there any interaction in terms of any reports in the hospital or any changes, or to have a look at you due to have a blood test done. So that's all time. So if you have a doctor's time invested in it, there has to be a small charge for that, because at the end of the day, you have to resource the running of your practice. So unfortunately, it can't be a free service if you're investing someone's time to have a look at your prescription.
Finally, Emmett, do you think this will become a reality?
I think, look, it's at a very early stage of feasibility, and I'd certainly say to Darragh, we all need to work together on this. And I mean, if something came of this, you could certainly look at maybe moving pharmacists into practices from point of view of a non-dispensing role, in a clinical pharmacist role, who could come in and have a look and audit prescribing habits in general practice, and that could also be to the benefit of the patient.
Same question to you, Darragh O'Loughlin. Will you be putting your size 12's jackboot to stop this?
We don't have a size 12 jackpot, Ivan, and I don't think that it will be necessary. Interestingly, the point that you made about the repeat prescription in Canada, where they also have a shortage of GPs, pharmacists can extend a prescription where no change in the medication is necessary, when it's quite obvious from monitoring the individual, the patient, that no change is necessary because the medicine is doing what it needs to do.
Okay, we'll conclude this with two final texts from our listeners. There are at least 34 pharmacies within 1.5 kilometres of my home in South Dublin. There are fewer convenience stores in the same area, says Carl in South Dublin. And somebody else said, is it a good idea or ethical for GPs to be effectively selling drugs for the pharmaceutical companies? We will await with interest the result of this feasibility study, and whether it comes about, and whether what's exactly happening in relation to medical medical card holders in terms of some community doctors will be expanded. I'd like to thank Dr. Emmett Kerran, President of the National Association of General Practitioners, on the phone, and in studio here, Darragh O'Loughlin, General Secretary of the Irish Pharmacists Union. Thank you both for joining us on Newstalk Breakfast.
Now it's 17 minutes past 9. Back to